Welcome back, everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got the usual crew with me here today. We got Caleb Ferroni to my left, and occupying my right seat here is the Ray Pace. And over there, our guest of honor. Thank you for joining us. This is Dr. Regina Yaskey from Rainbow Babies and Children.
So thank you for having me.
No, we've been looking forward to this. We originally had this scheduled a while ago, and then you had something come up, and
an emergency.
Things happen, right?
Things do happen.
Yeah. Turns out we have personal lives too. So right, yeah. Everybody thinks we're worried about everybody else's health and well-being, but
thank you for being flexible.
Hey, no problem. I'm glad we got you on, and so. I guess first and foremost, let's tell us what you do. I mean, you're...
So I am a pediatric emergency medicine physician by training.
Yeah.
I did my fellowship. Well, I started with residency in pediatrics and then did a 3-year fellowship at Rainbow Babies and Children. I do a lot of work with disaster medicine, and I realized disaster medicine kind of goes hand in hand with pre-hospital medicine and working with some of the pre-hospital medicine providers. EMS rotation was actually my favorite rotation. I did a lot of ride-alongs during my fellowship, so I kind of thought, I was okay, well, let me do this as well. So in 2021, I did a year-long EMS fellowship, graduated last year, and so now I am the first pediatric EMS medical director at Rainbow.
That's fantastic.
And I work on, all of anything that has to do with pediatric with the EMS Institute, basically.
I know. We're always working on stuff with protocols and what the future is going to look like. And
it's very interesting to be an advocate for kids.
It is. It's also it's also fun because it's also fun for us because we get a new set of eyes.
Yes.
On those protocols. I mean, the stuff we've been working on here recently was. It's been in there forever, and you're like, nah, maybe that's not exactly. We can do better, right? And of course, that's what it's all about. So, I guess the fun part is you kind of mentioned the disaster medicine. How do you take an interest in the disaster medicine? Was that born out of anything, or you just were looking at a menu one day and be like, wonder what this is? Let's do this.
Yeah, it actually started during the Ebola crisis. My family is originally from West Africa in Sierra Leone. So Ebola was devastating to that region.
Absolutely.
Even before it came to the United States. Thankfully here it wasn't as terrible, but you saw the alarm that went off. So I knew a lot of people personally who passed away, and I had extended family there, so that's actually how I started with disaster medicine, just volunteering with the Red Cross and trying to do what I could, and just kind of learning on my own and going along. What can I do? I live here, but I was okay, let me see what I can do to just kind of learn more. And disaster covers, as we could see, you have epidemics, and then you have, of course, what we saw, which was centuries old. We had a pandemic, and then you have things that we're seeing now, active shooters, mass casualty incidents, and things like that. So, my job at my hospital is just make sure that we are prepared, call it disaster preparedness and response. Let's make sure we are prepared, because the one thing I say about disasters is you hope it never happens to you, but when it does, you want to be ready, you want to be prepared.
Right.
Take care of your patients.
That was a lot of the talk. Yeah, that was a lot of the talk of our tactical medicine, of our TAC Med series, and Dr. Dare was here, and it was much the same message as you hope it never happens, but we have to be prepared.
We have to be prepared.
Again, that was more active shooter stuff. But
yeah, we talk a lot about peds in that. I mean,
that
atmosphere is, unfortunately, a school is
shooting or something to that.
One of the places it could occur, and Rainbow's being a level 1 pediatric trauma center is very important to be prepared for that type of thing. So,
you're going to get a serious influx.
Oh,
right. Well, and it starts from the pre-hospital side too, with triaging them and making sure they go to the right institution, and just making sure they're taken care of at the site before they even get to you, because it starts there. So,
we see a lot of the trauma pages and some of the charts and stuff that gets triage downtown on a daily basis, it looks like a disaster from where I'm sitting most days, right? Let alone an actual, let alone an actual event.
Yeah.
It's still somewhat of a new topic too, though. I mean, if you think about disaster and preparedness and all that you're working with, to us, that's still semi-new. I mean, one of my EMS instructors, Alex Buttman, wrote one of the first trauma books for multiple casualties, and that's not that long ago.
It's not that long ago. Yeah, Oklahoma City bombing, I think, was the first one where they actually said, okay, let's put some government funding into this. Like, this is important. And then, as we know, in the Oklahoma City bombing, there was a daycare at the bottom of
was,
this.
absolutely
So multiple children were injured. And so that was when it started rolling in. And then, of course, Katrina was even worse. You had hundreds of displaced children, too. So government funding went there, too. So they saw that there was a need. There were gaps that needed to be filled.
And then NIMS really ramped that up, the National Incident Management System, with after 9/11.
That was really born out of those events, right?
Yeah.
Well, then you think Stop the Bleed, too, right? So it talks about, like, the Sandy Hook shooting, and then you had the Hartford consensus that came out of that. And just really kind of ignited the Stop the Bleed program a lot with the American College of Surgeons, and all these things.
That's a big one that we've been pushing at our institution, and the trauma team does a pretty good job of that.
So you're interested in pediatrics, you're interested in disaster medicine, and just for shits and giggles, you decide I want to be interested in EMS too.
Yeah.
So tell us a little bit about that fellowship, because I don't think. Well, first of all, what does that mean?
Yeah.
Because I don't know that everybody in the audience knows that component of your training as a physician and what other avenues there are for you, where you did that and.
Yeah, it's basically my work started in the ER, right?
Sure.
I'm in hospital, but basically just thinking of what happens in pre-hospital setting, because really they're the first responders. They refer to us as first responders in the ER, but the pre-hospital setting, they're really the first responders. So, my job is to make sure that I am an advocate for kids in that space, in that realm. Whether it comes with education, and I'm big on that, like providing education for our pre-hospital providers, making sure that the needs of the children are met, and making sure, not just education, but we have the right equipment, things like that in our trucks, in our agencies, working on QAs, making sure the protocols are followed, rightly so. And as you know, Scott, also working on the protocols to make sure that children are included and they're done accurately as well.
That fellowship you did here at UH, right? I know we take it for granted because we're in all the meetings and we know what goes on. But UH actually helps train.
They do
the next
work with
the next level of pre-hospital physicians, right? Such as yourself. And like you said, recent graduate of that.
Yes, sir.
21. So
21.
that's awesome. And of course we appreciate the optics on the on the kiddos, because although all of our other docs are EM guys and gals.
They're all EM. It's usually like an offset of EM, but I really wanted to do it as a pediatric EM, and thankfully, the programs was supportive, the hospital was supportive, and the program director was supportive when I applied, and so it was good. It worked out.
Oh, excellent!
I'm happy it did.
I'm breaking my own rules here.
Well, I know we always look forward to seeing your con eds too. I know that you write our con eds at least once, maybe twice a year.
Yes,
so
I do.
Those are always good, and always get good information out of them. So again, peds are so out of the ordinary for us in EMS. When it happens, we're least prepared for it because it's the least practiced and the least acuity. So it's something we need to really ramp up.
I agree, because it's just such, a lot of departments that'll take, like our department will take 4,000 runs a year, but out of that at PEDS, it's such a small percentage of it. So it's just,
another reason that was so awesome to see that the Certidose syringes show up.
Yes.
That took a lot of anxiety out of people when they was like, oh, there's a cheat code here.
I like that. There's a cheat code for it. Yeah.
I always say you can't cheat after you pass registry. After that, cheat, in EMS all you want because there is no cheating. Phone a friend, phone the doc.
Phone a friend, look it up, right?
And I will tell you, every time I go to the agencies and I speak to pre-hospital providers, they always remember a PEDS case. Like, you always remember your PEDS case.
Yeah.
You see, maybe hundreds of adult cases, but you always remember your PEDS case. Yeah.
That's
Those are the
true.
ones that make you like, oh, okay.
They stick with you. Yeah, they
stick
stick
with
with
you.
It's just a small percentage, and then I think they're more impactful.
They're
too.
more impactful, exactly.
And I think that's why the education piece is so important, and a lot about what we're going to talk about today is it's just they don't happen as often, right?
Yeah.
It's just, why do we talk more about mass casualties? Why do we prepare for these disasters that may or may not happen? And why do we prepare and do so much education for these pediatric patients? Just because we don't see as many as you.
Right.
You see adults.
When she said that, did you flash back to a particular?
Everybody did.
100%
As soon as that came out of her mouth, I went right to one patient.
Yeah.
It's. I mean, I could.
I'll talk about that on the fourth bullet point.
I
Sick
could-
versus not
I
sick.
could draw. I could draw that. Slide by slide.
Really?
Okay, that whole call over again. Yeah.
It sticks with you for
Indeed,
sure.
indeed, it is. So let's get to some meat and potatoes and really some more clinical stuff about the kids. And I'm going to bait you a little bit because because the old mantra was that the kids are just little adults.
I still
right?
hear that to this day.
I know you do. I know you do.
I think I just heard "quote unquote" only neonates.
I wanted to see if she'd come across the table and pummel me on camera.
Please do.
But here's the good news.
Yeah.
Nearly every time I hear somebody quote that, it's usually in jest, like me here, and it's usually followed with, "I think we gave up on that 15 or 20 years ago."
Yeah.
So, but sadly, I don't say sadly, but a lot of us 20 plus year guys certainly remember, and it is really hard. You practice like you train, right?
Yes.
And if you're stuck in that mindset, I mean, sadly, I think our default is that, and we have to work out of that. Probably easier for a newer provider because we're teaching the more current than certainly we were taught. So I know
Right.
certainly I was taught in the late 90s.
Even us, I had attendings who would say, "Oh, kids are just like little adults."
Sure.
Like I had that going to school, so I definitely get it. I understand.
I think I agreed with that and somewhat believed that until I had kids, and then it's like they're not.
Yes,
They're not.
They
That's
bounced. She
very true.
just fell down 5 steps and she got right back up. As long as you laugh, they're fine.
They're
I
resilient.
did not push her.
Yes.
But no, I think that when I had kids, my attitude changed, and
Yeah.
now I wouldn't say scarier. It's just I have a better understanding that they're not just little adults.
Yeah.
Their own anatomy is
It's very
very
different.
alien.
Yeah. I mean, for starters, their airway is smaller.
Yeah.
So, for example, when I think of a little one, we say they're obligate nose breathers, meaning they breathe through their nose. And so when they have a cold, for example, and they have a lot of edema, swelling up here, you're going to see it down here. They're going to work really, really hard to breathe. And we'll get to that. We'll talk about that. But I think a lot of people listening to this will remember, they won't forget the respiratory surge we had last year in the fall,
right.
From October till like December, early January. And it was tough. We'd never seen anything so bad for about 20 years. And a lot of these kids came in with, respiratory difficulty with bronchiolitis. So, for you and me, it may just be a cold,
Right.
sneeze it off and, have a cough for a few days. But with little ones, it's a lot more, They have increased metabolic demands. That's another thing, too. The respiratory reserve is not as great. So, you have a little one coming in, whereas it may take you, a day or two to just lay down and say, I don't feel well, I don't feel good. For them, they're really, really working to breathe. They're flaring, they're grunting, they're retracting, and we'll get to that a little bit more. They're positioning, and for the little ones or even for the babies who can't really tell you what they're going through, it's really, really hard. So, like, for example, normal airway, like a smaller airway for a little one, would be about maybe 2 to 3 millimeters, and for an adult, it's 8 millimeters. So if you even have like 1 millimeter of edema there, it's gonna like shrink it to this. Where if you have 1 millimeter of an edema in an adult, there's still
right?
room
Yeah, absolutely.
to breathe. This is why, we encourage paramedics, if a kid has a cold, seeing them working to breathe, you want to suction them. And of course, if their oxygen is low, you want to put them on oxygen too, because it really helps them. There's some hypoxia there. So that's one. And then they can't compensate as well. Go ahead, Scott.
I was going to say, I think that that suction piece is probably one of the more underutilized, simplistic things.
Very simplistic, right?
Everybody can just suck them out. If you don't know, suck them out anyway.
It's a fear factor, but most books that you read for paramedic school even will talk about vagling kids out with suctioning, and I think that is red flags for us, and we need to get away from that thought.
Yeah.
We're not vagling them.
No,
you are, but not the way that we think.
No.
Well, I think, too, to your point, Caleb, I think until a lot of people have kids, like until I had, my own son, I kind of felt that way. And then kind of to your point, their airway's smaller, their nose breathers. I think once you have that child and they're like, all right, they're getting stuffy, I'll use a bulb syringe, suck their nose out, and then you see this 50-cent, bulb syringe has now improve their breathing dramatically, and you're like, well, this is such an easy skill, right? And we kind of get away from that whole like it's taboo to suction them, we're going to hurt them, and it's really not. Like just easy BLS maneuvers, for lack of a better word, are going to really promote better breathing. But I think you understand it better once you have kids, like in our world, just because in your world you're around them more. So in our world, now that you have a child, you're around that child more. You understand them better. You can
it's different than
relate
maybe
to them
encountering
better.
3 during clinicals or a mannequin when you actually are around it every minute of the day that you're not at work, which for us isn't often. But you get to know them and you get to know the differences, and it's huge.
It's huge.
And the one thing I joke about is like we had our daughter, she's 7 now, and we have a 4-year-old. But when the 7-year-old was born, I spent a lot of time just feeling pulses. And my wife was like, "What are you doing?" I'm like, "I got to feel pulses."
I'm learning normal. Yeah, I'm learning.
And it's been nice because as she matures, I got different pulse areas, and it's like, okay, these are now stronger, and it's like it's just it's a learning opportunity, and it makes me more comfortable. I have the luxury that I spent a year or so working at Rainbows back in the day, so I had some comfort, and then I got a few brothers and sisters, so I have some comfort there too. But not everybody has that luxury. So you have to get out of that uncomfortableness, and it's sad, but most of the encounters I've had with pediatric patients are, you get the dispatch information, you get on scene, and somebody's running out to the ambulance to throw somebody at you, and it's fix it. And I'm expected to fix it. So
that's a bad start. It's bad when you're pulling up and they're running out of the house with the infant or the young child.
I get goosebumps now even. It's like
that sets the whole stage for the call there, And then too, I think as you start to learn your own children, not only how they're different, their anatomy's different, you also understand how to relate to them better, right? I mean, I remember having a child and you're trying to communicate with, let's say, that toddler on the way to the hospital, and they're just looking at you like you're a foreign animal. You are. And now it's like, you want to talk about Paw Patrol? What's your favorite show? Like, it's just stuff like that. And just trying to communicate with them is a different stance, on, what are they like, what are they into, and then you kind of base that off of what was your child's age and what did they watch, or you can compare, well, hey, my son just they're developmental stages of it.
Appropriate, like
Tayo the little bus, Blippi,
the way they look,
Blue's Clues,
Bluey,
Bluey and things like that.
You have to relate to them, and then they feel
we're
more
on a
comfortable.
Lion King kick right now. We've seen it about 100 times.
I always talk about like the pediatric assessment triangle, where I'm like, it takes you like 30 seconds or less, but it's really good because when I look at kids, even when I get residents coming in or medics, exactly. Are you sick? I always say, they want to read books and they want to do all that, and I think that's great. Like coming up with differential diagnosis, that's wonderful. But I always say at the end of this rotation, I just want you to be able to look at a kid and tell me if they're sick or not sick. If you can leave here with that, like, I feel like that's adequate, because then like, when you need to escalate care. Like, that's important, instead of just looking at a kid and say, oh, you're not sick. So I always talk about like the pediatric assessment triangle. So it starts off with like appearance, and then work of breathing and circulation. And even with my medics, I talk to them about that, because appearance just, you're looking at a kid and then you're like, okay, so how do they look to you? How do they look? How's their tone? Are they hypotonic? Are they just floppy?
Yep.
Or are they hypertonic? You know, their interactiveness. You talked about interactiveness. Are they talking to you? Are they, you know, do they just want to be with mommy or daddy or their caregiver and pushing you away? That's okay. They're
Right,
being
right.
interactive.
Correct.
That's
Are they
normal.
making eye contact with you and pushing you away or screaming at you? That's fine. That's, you know, that's appropriate. You know, are they easily consolable? When mommy takes them, they're okay. They're, you know, that's fine. You know, their gaze, we talked about their gaze. That's appearance. And then, you know, you talk about work of breathing. That's where it gets crazy, you know. Are they grunting? Are they retracting? And that can be really scary when you walk into a home and, you know, the kid is really, really working to breathe. And a lot of like pre-hospital providers saw that, like during the respiratory season. You know, when you listen to them, do they have decreased breath sounds like you would have in like an asthmatic child? Do they have stridor, like, you know, the high-pitched upper airway, you know, obstruction thing? And then their circulation, you know, are they mottled in appearance? Are they cyanotic? You know, you want to look in their mouth, you know, their lips and, you know, their finger beds. Mine is pink right now, but, you know, their finger beds. You know, is they looking blue? And, you know, their
To your
pallor
point,
too.
that
Do they
is
look
so
pale?
important, though, because
Yeah.
I like to refer to that as a doorway exam. I'm not touching the patient yet, because if the patient,
You're not touching them, right.
pediatric
Just a few
especially, is
seconds.
acting normally, once I lay hands on that patient, you're not going to get
You're
that
not going
information.
to, exactly. You're
So,
not going to get
yeah.
the information. They'll be crying, they'll be screaming. And, you know, so a lot of times, you know, if a kid is working to breathe, for example, they have tachypnea. It's good to just kind of watch them and count, because if once you start, they're going to start screaming. Your
Correct.
exam is not
Yeah.
going to be accurate
Right.
at all because they
Yes.
start screaming. And I get that a lot. People come in and be like, I could not get a good exam. They're screaming, they're fighting me, they're doing that. Like, I don't
And you kind of
understand.
sit back and go,
and to your point, that's
Comfortable.
that's counterintuitive for most providers, right? Is just to walk in and just observe
Yes,
for a
yes.
minute, right?
'Cause you wanna start right
Because
away, right.
we want to go to work,
You
right?
wanna go to work.
Yeah, right.
you know, there's so
wanna
many
back
more
to bed or
important
get to
numbers
dinner.
than struggling your entire trip to the ER trying to get a blood pressure on a 2-month-old because they're moving and they're screaming. And it's like,
Exactly.
stop. Their color's good. Their work of breathing's
Right.
good. They're and you're right. So
Right.
look at their fontanelles. You know, look at their palates. They're-
Well, I think a lot of that too is like to your point, and doctor, to your point, is whenever we get a ped call, and I'll use one case that comes to mind. We responded to our local urgent care, and you walk in the room, and there is, you know, the child. I don't know, probably 1 or 2 years old, and there's mom's panicked. You know, you look in the room, mom's still panicked. You can tell the nurse at the urgent care, she's kind of panicked. Here's this child that does not look at us when we walk in the room. You can see the respiratory rate is tachypnic, really working to breathe, and then we're having periods of apnea. And then just
Yeah.
from the doorway, I was
Scary.
like, let's put the child on the cot.
Sick or
Yeah.
not
Let's
sick.
go. Sick
Yeah.
or not
And
sick.
you've
I
been
get
telling
that.
you sick.
You move to
that's-
sick,
I
and it's
completely
like,
get that,
I really
yeah.
only need about a minute worth of report, and then we're out,
Yes.
right? So a lot of that pediatric assessment triangle comes into play on, am I going to sit on scene or not? What are my immediate interventions? You know, I can see we have periods of apnea, so we need to address the airway. Do we
Yeah.
need to ventilate this child? This is not
Any
something
seasoned
I
medical
want to
provider
stay
is going
here
to know
for.
that they decline the quickest.
They do.
Yeah.
They don't compensate as well. Like they are resilient, but once you get to that point where like they can't, it's just like boom. Yeah, they don't.
Yeah, once they
just
hit the
goes
wall,
down.
it's straight
yeah.
down from there. Yeah.
And we have an interesting clientele in the area, especially here with the Amish population, because you have a lot of
yes.
non-vaccinated
Yes.
groups. You have a
Yes.
lot of things that you wouldn't expect to see
Right.
elsewhere.
I agree.
And that really brings up some challenges sometimes. I don't work with them much anymore, but when I worked at Dr. Fallinger's office in Chardon, we had Amish clientele all the time, and it was just very different.
It is very different. It's very good education though, because you get to see things that you haven't seen. Like for
Should have been
example,
eradicated almost.
Yes,
It's-
almost
Yeah.
eradicated.
Yeah, exactly.
For example, epiglottitis,
Yeah.
which you know is in the textbooks, and it's a good one to know. But we don't see it as much anymore because we have the Hib vaccine. That's something you could see. I saw tetanus, which we don't
was the
really
last
see
time?
anymore.
Yeah, exactly.
Yeah.
And
No, that's true.
Yes.
Just cultural issues.
Yes.
Tuberculosis,
Just
I've
cultural
seen-
beliefs.
I've seen,
Yes.
you know, chicken pox is rampant, and it's just things you wouldn't expect.
Yeah, that's true. The only case that I had of a couple of epiglottitis were in the Amish community, and it's just the cultural differences that really come forward. And then, two, their culture is not one to overutilize 911 or physicians or emergency rooms. So, usually when that family has called 911 or they've brought the patient to the emergency room.
The patient's really sick.
They are really
help.
sick.
Yeah.
MRSA is another big one there too. It's but yeah, different clientele, and it's very eye opening.
I think another piece of this is specifically today with newer providers. I'm not dogging new providers, but they often grew up in a very technology-driven society, right? So in adults, oftentimes I see, specifically my younger providers, going to the technology to support, to form their conclusion, right? Is pulse ox is low, this must be a respiratory thing, right? Instead of looking at the patient, right?
Yeah.
And in a kid, you need a whole nother set.
You do.
You need that touch feel, that stick and rudder, patient assessment. Oftentimes, they're throwing the leads off, or the pulse ox that goes flying across the room, right? And you need to just, be able
I
to
do
do
like
those
to think, though, in my mind, that
Yeah.
if I get a pulse ox with a good reading on a kid, it's probably the most accurate pulse ox I'll ever get. I mean, they're not scarred up in their fingers like we are, or bad circulation. It's probably what it is.
Yeah,
I always
they keep it on.
ABC, but with kids I say AABC, so airway, breathing, circulation, but I add another A in front of that A, appearance, airway,
Sure.
breathing, circulation. You want to look at their appearance first and then go to airway, breathing, circulation, for sure.
So let me ask you this.
Yes, sir.
We've talked a little bit about the pediatric assessment triangle, and so we can talk a little bit about maybe using the Glasgow Coma scale as opposed to using the APGAR scale. At what age do we stop using the APGAR scale? Because if you read the textbooks, it doesn't really ever allude to, they're 2, don't use it. Or they're 6, don't use it. Do I really look for a cry and a whimper at 6?
Yeah, I usually just use the APGARs like in babies. Like
Newborns.
babies, the newborns, basically. And then after that would be IQ or GCS.
Yeah, and I think that nothing really defines when to make that cut. But I just like thinking like you do, that a baby is
A baby
APGAR.
would be like a baby born. Definitely, I would use like an APGAR to kind of look at them and make the assessment. And then from then on, I would kind of like go with GCS. It is very difficult in the younger ones. I will give you, on the GCS, and that's really when you kind of take a look at them. You look at their mental, because GCS basically is a little bit of, mental function, and also, neurologic function. That's a big one, and thinking to yourself like, will they be able to protect their airway? So just the little ones, it's easier to just kind of look at them while you're evaluating them to make that clinical judgment. The older kids, though, looking at your GCS scale would help you to kind of make that assessment and go forward. Yeah, but definitely the AFGAR would be for the babies.
Yeah.
Thank you.
And well, I mean, there's also the angle of, if we're doing so few of these, right, is, the average paramedic, going to be able to take the time and recall that or find that and apply that, right? And I think in those cases, and correct me if I'm wrong, but if I'm calling you and I'm bringing you a sick kid and I am having trouble working through, a GCS with a kid, if I could just explain to you in plain English, this is why I'm concerned,
that's appropriate.
right?
Yes.
Might be as impactful. And yes, advanced providers, I would hope, get to a point where we can speak. Hey, their GCS is 13, is 14, is and
And
even
then
that be
sometimes
meaningful.
we want a little bit of clarification. Like if you're telling me, okay, we're thinking GCS 8 or less, they can protect her. I want a little bit more clarification, and not just in the pre-hospital setting, sometimes in other hospitals too. We just kind of want, because when we're looking at GCS too, GCS sometimes can be subjective. So I usually recommend whoever started the GCS, the first pre-hospital provider who started the GCS should be the one who continues doing the repetitive GCS.
That's a good point.
It shouldn't be different people doing it, because then it's a little bit subjective. That makes sense.
It's more objective
right.
if one person.
If one person does
And
it.
I've
yeah.
literally
makes a lot of
seen
sense.
that take insult to paramedics that have brought patients to the hospital, and they say, I had a GCS of this, and somebody else says, no, it's this. Don't take that as an insult, but like you said, they're seeing something you didn't, or vice versa, and so that's a great point.
Bring some consistency to it. Yeah,
That's
so
a great
whoever
point. Yeah.
started it should be the one who
Trends it, yeah.
who's assessing it, right?
Or your patient changes. You know,
Or your
that's-
patient-
you know, you got to think
yes,
that
they
just
do.
be. I think sometimes we get hung up on that number, and I'll be honest, I'm a dumb guy. I say that a lot.
We know.
And yeah, exactly. I'm a dumb guy. I'm a bread and butter paramedic. So you know, if I made that call to you as a physician, I'm going to say, hey, this child. I'm probably going to say the child's sick or not sick right out of the gate. I believe this child is sick, and then this is why. You know, they're tachypnic. They have periods of apnea.
And
we're
we
ventilating
appreciate
this
that,
patient. So it's
yes.
like I'm probably going to give you the picture of it, and I'm going to be a bad advocate for paramedics here and say I'm not going to give you a GCS. You know, it was kind of like the first baby when you said APGAR. It made me remember that, and I called and I was like, we just delivered this baby, and it's a beautiful little girl. And you know, and they're like, what's her APGAR? I was like, hey, we're warming her up. We sectioned her. We did this, and they're like, do you have an APGAR? I was like, no, I sure don't do that. Didn't do that, but we're doing better. You know? Yeah, the extremities were blue. Now they're pinking up.
They're pinking up.
Yeah,
Yes.
you know, I move in
They
that
cried.
direction.
Yeah.
And it's just, I'm poor with a number, especially on that, like a pediatric GCS.
That's
I couldn't
okay.
even tell you last time I did one.
I brought that up because I don't think you're unique in that situation.
Yeah.
I think I'll say a fair amount of pre-hospital providers. Again, we don't do it. You do it every day, right?
Yeah.
It's
proficiency of it too. I mean, just down to the point of like proficiency of it, repetition of it, and you know, so if you're that provider out there that is not going to be as proficient, and even with using tools and aids, maybe just plain English. Hey, this is what I see. This is what I've done. This is what I'm finding.
What I'm concerned about.
That at least paints the picture for you receiving that patient. And then what other service lines might I need? Maybe do I need respiratory? Do I need these other service lines to meet me?
Don't be afraid to make the phone call and talk to med control.
Yeah.
I mean, this is one of those incidents that to me it's like LVAD. If I have an LVAD patient, I'm going to call the LVAD team and speak directly to them about what's going on with my patient. If
They're the
I'm
pros.
even going to Geauga Hospital with a pediatric, I might call you downtown and say, this is what I have.
that's
What do you
okay,
think?
right.
And I think that people have to understand that this is
appreciate
kind of
that.
a specialty. And yes, Geauga will take it, and they have docs that are trained in it, but you might want to talk to poison control first and say, hey, this is what I got, and then get that ball rolling, because ultimately they're going to probably come to you anyways. So...
Agreed.
But no, I don't think we should be afraid to make the phone call, even if it's downtown to you, and say, hey, what do you think before I get to Geauga? Should I fly this? Should I come right to you? Should I even go here?
Thank you for doing that, because we do appreciate like early calls so that we're in on the discussion. Like, I think that's definitely very helpful. So if the kid is going to like another UH hospital, they can stabilize.
even a
And
non-UH
even-
hospital.
Exactly.
Yeah.
Even a non-UH hospital, and then we're part of the discussion because,
Right.
like you said, ultimately they do end up coming to us.
Especially,
yes,
a trauma, right?
A trauma. Oh,
I mean,
and all that.
you can
So
right
we
click, you can right click, save
Yes.
that. Like, I'm going to see them in an hour, right? Or I'm going to see them in 2 hours, even though they're making a stop.
I think that's huge, though, in today's paramedicine. Is one of the reasons we call this the pre-hospital paradigm is because that this is new. We are
set the standard.
and part of our paramedic, the way we teach now, is that we're diagnosticians in some ways, and ultimately our goal is to get them to where they need to be the most, and that might not be today, but it might be down the road that we followed the right chain. So I think that establishing that with you earlier, like you said, is better. So
I agree.
Yeah, well, I mean, even if wherever you take them doesn't institute the call with, say, R, B, and C in this case, right? When they're like, that's not really bad. Hey, hospital, tell us about that kid that just came in, right? I mean,
I feel bad now.
My optics are you guys just take ownership of all kids in the system, no matter where they're at. That's my kind of how I see it working, right? But,
I mean, God bless her, Ann Falinger. I always thought, and I'm probably going to regret saying this, that she was just crazy because she would call early on pediatric patients and call downtown and get them transferred out of just the doctor's office or send them to Geauga to the ER from there. And I was like, why? And then learning and then following up on some of those, it's like, she's dead on.
She's dead on.
She's dead
She
on.
did
And
it
she
early
saw
on.
something that I couldn't see, obviously, through a lot more education. But it was truth. And it was neat to see.
Yeah. It's early recognition, prompt intervention, and getting them where they need to be. And that's really where we come in as pre-hospital providers, really.